Hello, it is September 20th, and we are here today with Jessica Malaty Rivera, who is, per normal, we're going to hand it over to her to tell you about who she is, what she's been doing, how incredibly busy she has been throughout the course of the pandemic, and to help us all understand a little bit more about what she's been doing, but also about the challenges of being a communicator during this really kind of challenging time. So with that, I am just going to hand over directly to Jessica. All yours.
Thank you. Thank you. That was not awkward at all. That was lovely. Thank you so much. I'm going to share my screen if I'm allowed. Yes, here we go. And just don't even worry about how crazy my desktop is. It is always like that. Okay, so my name is Jessica Malaty Rivera. I am also a Georgetown alum. In 2011, I graduated from the Biohazardous Threat Agents and Emerging Infectious Diseases program, where I got my master's degree. While I was at Georgetown, I was actually working for Georgetown on a government-funded project called Project Argus that was funded primarily by the Department of Defense. And our objective was basically to track indicators and warnings of emerging biological threats that could become the next pandemic. We tracked these events in humans, plants, and animals. We did the surveillance by hand using open source media, and we tracked that information in about 50 languages. I covered Arabic, Spanish, and Portuguese media. We would translate these reports that we would get from all kinds of open source articles. We would translate them into these pithy summaries and scale them using a scaling algorithm on how to kind of find what could potentially become a disruptive event. We did everything from tracking, ventilator shortages to political instability, because all of these things kind of work together as puzzle pieces to kind of indicate what could be a potential threat. Our team actually did identify the emergence of the 2009 H1N1 pandemic on a farm in Mexico. Our South America team and LatAm team was finding these unusual reports of farmers getting sick and respiratory illnesses that were undifferentiated viral fevers that were being reported in that region. And putting those pieces together gave us a head start in identifying an unusual event there. So pandemic surveillance, pandemic research has kind of been in my world for a very long time. I remember being in graduate school at Georgetown and being that girl at parties when people would be like, so what are you studying again? And what are you worried about in the future? And I would always say a viral pandemic, some respiratory disease that kind of takes us by surprise, probably a coronavirus. And that was not clairvoyant. That was, of course, what everybody in this space has been saying for quite a long time, that it was always a matter of when and not if. Sadly, that research actually got defunded by the US government, as many public health programs did. They brought that stuff in-house and it kind of atrophied. I remember throughout the last several years of my career hearing from people like, whatever happened to that? And I wish we had a kind of weather channel for infectious diseases. And it would kind of kill me to not scream and say, well, we had it. There were programs, including Project Argus and including ones at Johns Hopkins and including ones internally at the government that were shared within networks that were trying to do that very thing. But as we've all kind of seen, a systematic devaluing and defunding of public health and biosurveillance has kind of led to the tremendous disadvantage that we were faced with when the pandemic emerged. So right now, 10 years later, I wear a lot of hats that all kind of are related to the work that I started at Georgetown and all kind of worked complementary to each other. This intro slide kind of tells you the few hats that I wear. I'm an infectious disease epidemiologist. My undergrad was in public health. I spent a lot of time doing data. I did my time in Stata, in SAS, and R, did all those things. So I kind of have those bruises and cuts from all that time in the numbers. I'm a research fellow at Boston Children's Hospital with the Department of Innovation and Digital Health. We're doing a lot of epidemiological studies on syndromic surveillance and social media data, which is really, really interesting. I'm an infection preventionist with Netflix, which is probably my most interesting hat that I wear. I work with a team of IPs that basically help keep film productions safe. We do everything from creating testing cadences for different productions to actually doing script review and identifying high-risk settings, everything from intimacy to fighting to singing. And Netflix is actually kind of one of the standout organizations that has kind of prioritized public health and epidemiology and hiring experts to keep the work continuous. Everybody from a grip to the most highly paid talent has had continuation of work with that company because they have really prioritized public health. And then I am the former science communication lead of the COVID tracking project, which I'm going to spend the majority of my time talking about that experience, as it was the majority of my work throughout the pandemic. The work has, it's since kind of slowed down a bit. I'll kind of describe a phase 2 that I'm a part of COVID tracking project that's not quite public, and I'll share that with you all in a little bit. But here is a little kind of journey through that time at CTP. So you're probably familiar with the incredible science writer Ed Yong, who famously called the pandemic this patchwork pandemic. And throughout the pandemic, that was kind of the understatement of the year. There was a patchwork response, as a result, patchwork data. And when you have patchwork data, you have patchwork interpretation, patchwork communication, patchwork everything. We were tracking this stuff in 56 different sections of the United States, 50 states and 6 territories. And as a result, it made trying to make sense of the data an incredibly endless job. So the COVID tracking project compiled and published the most complete data about COVID-19 in the US. For over a year, our mostly volunteers teams analyzed testing, hospitalization, and outcomes data from official US state, territorial, and federal sources. Where exactly did the data come from? So we only compiled data from official, public, state, and territorial sources, and that testing and outcomes data we would update every single day. We had a race and ethnicity tracker that I'll talk about in a second that we updated twice a week, and then a separate long-term care facility update tracker that we updated once a week. The long-term care facility data was incredibly difficult to manage. As you know, there were a number of states that were managing their long-term care facility data very differently. What we saw was just scratching the surface of, one of the most devastating outcomes of the pandemic on this specific community. We did all this by hand, which allowed us to maintain a very close relationship with the data. We provided very, very granular annotations with data definitions that needed to be updated and identifying all kinds of anomalies. We kind of became famous for our caveats because we were noticing that a lot of people wrote about the data without the caveats. And so we tried very hard to be very, very clear about how to interpret the data every time we shared data. So we had this race and ethnicity tracker. This was in partnership actually with the Boston University Center for Anti-Racist Research. Ibram Kendi was our partner in this research. Together, we gathered the most complete and up-to-date race and ethnicity data on COVID-19 in the US. This data was incredibly difficult to manage as well because we are dealing with data that is based on a very kind of broken and incomplete system of tracking demographic metadata in the US based on the US Census. The US Census has never fully been able to represent the kind of diversity that we have in the US. And so as a result, there were a number of communities who were either just falling through the cracks when it came to this data. And as a result, it just made it very difficult to provide the kinds of resources and public health policies to help mitigate that. At the surface, though, with this broken and very gappy data, we were able to find some of the bigger conclusions that we found of, Black people dying at a rate that was at the end of our data tracking 2.5 times the rate of white neighbors. Just unbelievable disproportionate burdens that we were noticing, particularly among Black and Latinx people in the United States. Unfortunately, this data continues to be very, very patchwork, but we did see that in the transition team's plans, race and ethnicity data was a high priority for them because this goes beyond COVID-19. It is kind of a public health, mainstay that racism is a public health crisis and is an underlying condition of public health issues in the United States. And so this was just kind of revealing what was already known, that it would obviously be that people of color would suffer the most when you're dealing with a crisis like COVID-19. The long-term care facility data, as I mentioned, provided very crucial data about a very, very specific community, but it was very alarming because the percentage of the actual population of long-term care facility residents is 1% in the United States, but closer to the end, again, of our data collection, it accounted for almost 39%. That says 34%, it's an old screen grab, but almost 39% of US COVID deaths with a population that represents 1% of the US. So you're talking about just these concentrated outbreaks that were happening in these controlled congregate settings, and it was devastating, especially as they were scrambling to figure out how to manage the data. So in the process, we developed a lot of habits that helped us interpret the way we collect the data in a responsible and very cautious way. We definitely had a tone, and we were known for that tone. And I think it made us trusted between people and governors and governments of varying political spectrums. We had close relationships with red states and with blue states. And we worked as closely as possible to make this as apolitical, knowing that there was definitely, a political failure that led to the reason why we had to do this job, because let's be very clear, this is the job of the CDC, but it wasn't actually sufficient, so we had to do it. But we did make it very apolitical in the way we represented the work. These are a couple of our best practices. We prioritized clarity, putting the most important data associated with each metric front and center. We wanted to build trust through transparency, so that was offering very accessible ways, everything from a historical time series so that people weren't just seeing spikes in the data, they could understand kind of the context of a week, the context of a month, and the context of since the onset of the pandemic. And we wanted it to be very easily downloadable too. So we used a structure and a consistency to boost understanding. We kind of created these hallmarks of our data so that people kind of knew how they would have some eye muscle memory when they would look at our charts and look exactly where to find the peaks and where to find the anomalies. And I think that kind of cadence of very knowable and recognizable data visualization helped people of varying backgrounds, people who were data wizards and people who were novices and had never seen the kind of charts that we were producing, make it feel very accessible. Inclusivity was a major priority for us too. We wanted full access regardless of ability, device, or connection speed. We knew that people would be accessing our charts, our CSVs, our JSON files on mobile phones, on computers, in rooms that are private, in rooms that are not. We wanted all the pages to perform in a very kind of clean and efficient way with any kind of device, with any kind of connection in mind. We also wanted accessibility for people with different abilities. So we would use alt text even in our tweets. We wanted to make sure that it was readable by every single person, as many people as possible. And transparency. So no hiding data behind hover effects, making sure that anything that is a map can also be downloadable as a table or a CSV. We used a lot of maps, kind of heat maps, hex maps, everything to kind of contextualize what was happening with each of the states. Here are some of our public outputs. And this is what I mean about our kind of iconic 4-pane chart. We would publish this chart every single day around 3 p.m. Pacific time, between 3 and 4, depending on when the last state's data was triple checked. We had a very, very methodical system of first round of data collectors, then double checkers, then triple checkers, then we would publish that data. I was part of the publishing team to make sure that we were making sure that all the numbers checked out and making sure that it looked correct on the data visualization. And then I would help with all the external comms. So every day we would publish the tests, cases, hospitalizations, and deaths. And I will say all of the details on this chart that you see were this kind of beautiful byproduct of this call and response relationship that we had with newsrooms. Newsrooms would call us and give us feedback and say, hey, could you give a 7-day average? We would just love to kind of always have a 7-day average. On our first iteration of this chart, we didn't have that. Later, we got some feedback to ask for putting like a red dot on the chart for a daily record. So if hospitalization was a new record, you would see a red dot there. And those kinds of things made it better and better because it was a very responsive process of trying to communicate more clearly so that people who were using our data were also able to communicate to their, whether patrons, data users, or watchers, et cetera, would understand the same kind of level of understanding as they were trying to display. So this is what I mean of us being very known for our caveats. We over-explain because we wanted all that nuance and context to never get lost. So we were always clear on titles and legends and labels for charts. We wanted to always provide things like 7 days or 14-day averages so that people were not just kind of looking at a day and making a conclusion about a trend. We were noticing that that was happening a lot earlier in the pandemic, especially as states were kind of comparing how they were doing compared to other states in the nearby area. We were actually noticing some states acting punitively to states in neighboring areas, that they would say, oh, people from that state should probably not come to our state, because people were trying to control the pandemic and they weren't using the kind of contextualized data that they need to make those better informed choices. But yeah, so we wanted to provide notes with annotations and caveats explaining any sort of anomaly. If there were kind of weird events that were happening, we would add a special report on that, or a special note that you could click on, download, and we would put, if we, especially for our weekly updates, we would make it very, very clear of like whatever data anomaly was happening. And there were plenty of reasons for anomalies throughout the pandemic. I've kind of said some of these things of ways that we were trying to avoid bad takes, ways to kind of be very clear in your communication. These are kind of like public health comms 101 too. So understanding things like data schemes, making sure that data definitions are standardized. Some states were describing positive tests in one way that would group PCR tests with antigen tests and antibody tests early in the pandemic. And we thought, God, that is extremely problematic, because an antibody test has nothing to do with a diagnostic test. So when we were noticing that as states were getting better about parsing their data, we had to be very clear, like, keep in mind, this state is using this definition for tests and the state is using that definition for tests. So it just meant a lot of comms. We wanted to look for confounding factors, use any sort of established relationships between some trends. Some things were actually causal and some things were not. Being conservative about what we can know, saying we don't know when we don't know, which is a very powerful way to communicate and to build trust with your users, and being faithful, right? Just continuing to do what we're good at. We made it very, very clear early in the pandemic that we are not pandemic modelers. We were not going to create models. There were plenty of groups that were doing that. Our job was to synthesize, analyze, and share the data publicly and regularly. So here again is some more examples of our analysis. We learned a lot about HHS hospitalization data, and HHS hospitalization data became probably the closest thing to real-time data that we had throughout the pandemic. We could easily say that tests were often lagging, cases were often lagging, that people who were testing positive today, or newly positive cases, were probably tested a few days prior, maybe even a few weeks. Hospitalization data was very, very current. That was coming from actual hospitals almost every single day. And then we knew death data lagged especially long. So this kind of was one of the controls in our analysis. We would look at hospitalization data to understand kind of what was happening in the community, and to also anticipate future surges in hospitalization based on what we were seeing in the hospitals at that moment and what we were seeing in the testing and case data that was coming throughout that time. As we were winding down our research, HHS data was one of the reasons why we felt confident that we could actually wind down, because we felt, okay, HHS actually is a reliable source of data. Eventually, CDC data got more on track when it came to cases. It never fully got 100% on track like HHS, unfortunately, but we couldn't do this job forever, and it was never intended to be done forever. Okay, so here are some of the things that we kind of sprinkled throughout our weekly analysis that we would try to, without saying it verbatim, repeat to people that today's cases represent people who were exposed a week or two ago, that weekly trends provide a better picture than any single day's count, to watch out for data lags. So 2020 was not just the year of the pandemic, it was the year of the election, of countless natural disasters, of regularly scheduled federal holidays. All of those things happened and affected the data in significant ways. And so we had to remind people, we're dealing with a Labor Day lag here. We're dealing with a 4th of July lag here. We're dealing with the huge ice storm that affected a huge part of the Northeast. Whatever it was, we wanted to make sure that there was always kind of the actual confounding factors here in the environment that were going to affect how the data was being represented. And like I mentioned before, hospitalizations are more stable, and one thing that is the hill that I will die on till the end of this pandemic, that test positivity is easily skewed. Test positivity has become this metric that I think has become way too much of a crutch for a lot of jurisdictions to kind of say how well they're doing when it comes to viral transmission. On the surface, the calculation seems pretty simple. The number of tests that are coming back positive over the number of tests total as the denominator. But unfortunately, like I mentioned before, data definitions had not been standardized throughout the pandemic because the federal government didn't provide these standards. So sometimes you had as many as 56 different, slightly different, not wildly different definitions, but those slight differences, even on things like time series, like if people were using the tests in a day or the tests in a week, wildly skewed this metric. So we always urge caution when states or even other public health data collectors were presenting this metric, because it often was not as clear as they presented it. Our data was used throughout the US and international media. And like I mentioned before, not in any kind of biased partisan way. The Trump administration used our data, the Biden administration used and continues to use or continue to use our data. We helped persuade dozens of states to provide more complete and comparable data. We collaborated with HHS to work for quality analysis, for and to signal boost their release of dramatically better and richer hospitalization data that had ever been available before. They were very amenable to that feedback, which was really, really wonderful. We sadly didn't have that kind of favor with the CDC, for reasons that are known to us and not unknown to us and will probably never be known. And then we responded to thousands of media and general inquiries about the government data. We eventually started doing media trainings on Thursday mornings, an hour before the release of our weekly update. And we had, sometimes 100 newsrooms calling in to ask us questions about what our takes were on certain things, how we were feeling about certain trends. And it just felt like a really wonderful harmony between newsrooms who were trying to be earnestly honest about the kinds of work that they were doing, about the kinds of representations of the data that they were doing, and also just wanting to be better science reporters. I came in, I should have said this in the beginning, but when the COVID tracking project started, I found out about it through a tweet. Alexis Madrigal was the guy who co-founded the COVID tracking project, and it started as 2 journalists from The Atlantic and a single spreadsheet trying to track testing data. They couldn't find it anywhere. So they thought, let's just try to track testing data. And then it turned into kind of a rogue CDC on the side. I DM'd Alexis on Twitter and just said, hey, this is my background. And within an hour, I was thrown into every single Slack channel and had taken the role, assumed the role of the lead science communicator. And it was incredibly humbling. And I will say this too, I've said this many times, that this work at COVID Tracking Project has been the most meaningful work of my entire career. I say that confidently. It'll be hard to match this experience because the work we did was so sincere. It was intended to share public data because we felt very strongly that this data belonged to the people. And I worked with some of the most selfless and brilliant people with very, very Renaissance backgrounds. It wasn't just a team of people who had the same background as me. There was probably a handful of us that were this niche and specialized, but otherwise we had journalists, we had teachers who were retired, we had people who were scientists and just wanted some more access to non-lab work. We had high school students who were some of our most outstanding data checkers. And all of that was kind of, and we did, and I will say too, the work, we tried very hard to make it as egalitarian as possible. It wasn't a huge kind of hierarchy. There were a few of us that kind of led the project, but it was a really, really remarkable grassroots effort to respond in a way that we tried to, fill a gap that we felt was very, very obvious in the United States. I could go on and on. I don't want to belabor what you've probably already talked about in this class before, all the ways that the COVID data went wrong in the US, but I will probably end with this because I think I'm running low on time, that when we wrapped up our data collection, which was on March 7th of 2021, we did so because we felt confident that what we were doing was passing off the baton back to the CDC, passing it off to HHS and to an administration that had actually expressed to us that they were single-handedly using our data to inform their policies for their COVID-19 response plan. Now, I will say there were things that were promising in that immediate response, and then there were things that were pretty disappointing. Things like the way in which communications are not being prioritized, everything from the vaccine rollout to even how the CDC publishes their weekly analysis. It is lacking the kind of nuance and granularity that we work so hard to prioritize. Do I think that it's hopeless? No, but I do think that we have a very, very long way to go, especially in the time of this infodemic that we're in. So if you've been in infectious diseases, you know that with the outbreak of a pathogen comes outbreaks of misinformation. And while the COVID tracking project didn't specifically work on kind of debunking misinformation, all of the lessons that I just shared with you were intended to kind of help elevate the public's general science and data literacy so that people could be able to interpret charts, which can lie very easily, and interpret things from the CDC without these horrendously bad takes that would just happen all the time. I mean, one of the things I remember very specifically early in the pandemic was this claim that only 6% of the deaths were caused by COVID-19. And that was because of a chart that was just so poorly annotated on the CDC website that just failed to communicate something as specific as, no, this chart is actually saying 100% of these deaths are COVID deaths. Only 6% of them had one field filled out on their death certificate. So we're still seeing those bad takes. We're still seeing, some newsrooms fail to include things like data dumps and time series that kind of skew the data. But I think now that misinformation and disinformation have become priorities, or combating those have become priorities of even the Surgeon General, I would hope that this also means that science communication will no longer be an afterthought when it comes to pandemic response. Okay, I'm going to stop sharing my screen.
Amazing, and thank you for that. But before we let you go, though, can I ask what comes next? So, clearly the pandemic's still going. What does the next few months, the next 6 months look like for you?
Yeah, so this is, I kind of teased this in the beginning, but one of our partners in our work was the Rockefeller Foundation, and they have created what is kind of in a soft launch, the Pandemic Prevention Institute. So there are a team of what we have affectionately called ourselves the lingering nerds of COVID tracking project, who have started a new work with this initiative to essentially kind of do the phase 2 of data collection for the pandemic, which is tracking kind of what we're all talking about right now, breakthrough infections and variants. It's pretty clear that SARS-CoV-2 is not going anywhere, that endemicity is kind of the most likely outcome of this actual virus. But we also know that because this population is so under-vaccinated, that we in the US and many communities across the world are at risk of new variants emerging. So we're working on trying to kind of globalize this data collection, which, as you can imagine, if tracking US data was messy, global data is infinitely messier. So we are working with a number of partners, including Global.Health, including partners like Boston Children's Hospital and GISAID, to try to see if we can create maybe a global dashboard to identify the next variants that might potentially spread and cause as much disruption as the Delta variant.
So not much on your plate, just creating an entire global system, right? Listen, I just want to take this opportunity to just thank you for all the work that you've done. For I can only imagine how little sleep you've gotten in the past 20 months while trying to kind of improve the data and the reporting and the decision making around the country and the world. So just thank you so much for all of your efforts.